I've gotten a chance to kind of dig into your stuff a little bit since Ruby introduced us.
Right,
And I think she may have mentioned I trained through Upledger Institute,
right.
craniosacral work. I've been doing it for about 25
Okay.
years, and
So my work resonated with you,
definitely,
but
yeah.
yeah,
And
you
and
can come and training if you like. That's what we're looking for. We're looking for therapists who've done up ledger, who want to do training. You don't have to be an osteopathic physician or a physical therapist. You can be somebody, a manual therapist, or somebody who's interested in that, who's done up ledger, done some manual therapy. We're interested in you.
okay.
So yeah, we'll
Well,
talk about
I'm planning to work with you here in Minneapolis when you come next year. So
Oh, right,
it's
super.
it's it's already it's
Yeah,
already in the works.
I know she's got 12 practitioners already signed up, and it's
Yeah.
next year already. Wow.
So
Yeah, I'm
she's
going.
she's
It's going to
she's
be on
working
the
at it.
end of a yeah. So did she tell you it's the end of a long lecture tour I'm doing? Going to
Yeah, you're going to
Seattle,
be.
then up to Alaska,
Yeah.
around Alaska, and then back to Minneapolis, and then yeah. So as long as the polar bear hasn't got me, I'll be there.
So is this becoming more and more of your work right now?
Yeah, yeah. It's
Okay.
what I want to do. I would have loved to have done it 20 years ago because I'm getting a bit old. Been doing this a long time.
Well,
Don't
you
let
don't look
this.
it.
No, I'm 63 now, and
I'm
my
10, yeah,
hair
I'm
is
10 years younger. But
yeah.
you got the hair.
I got the hair, and I don't dye it, and people don't believe it, but I don't. It's just I'm a freak of nature. What can I say?
Wow.
Yeah,
So just so you know, I'm not going to do an intro for us. I just kind of jump into conversation.
yeah.
I'm going to
That's
I do that
great.
in post, just
And
so I
if
don't
I'm
have to bore
talking
you
too
with that.
much, just tell me to stop and
No,
ask another question
no,
because
my
I
goal
just
is to learn. So I mean, that's, this is great. And
okay.
so we'll kind of just get rolling here, and wherever I feel like it gets good, well, I'll just edit in. So we're
Right.
recording at this point.
Okay. Super.
And
Right.
and
Well,
when I started looking at your work and thinking back about my field of study, I've also gotten into about. Do you happen to know who Tad Wanvier is by any chance?
oh, tell me more.
He's written a book on glia and the glia interface as far
Oh,
as
all right. Oh,
this is
right. No,
concerned.
I
So,
should. I can't read, unfortunately, every book we're going about the brain.
but I'll turn you on to his stuff. I got
Yeah. So
interested in him.
send me a
He's
link for that. Yeah.
I think he's in his 80s probably at this point, but he's still teaching. He's been on the podcast, so you can listen to that if you're
All
interested. But
right. Yeah. Absolutely.
probably 8 years ago, something like that, I got interested in one of his courses that he started teaching about this. And it was pretty new information. And I mean, I think a lot of what we're going to present today is probably quite new in some ways,
Yeah.
in terms of the technology that we've been able to prove some of this stuff out with. But
Yeah.
you go back, back to the late 80s, early 90s with your intuitions. So
Yeah. That's it. Yeah.
what was it that you started seeing in your work?
Well, it's interesting because you say that because I've just been involved in talking with a lymphedema and lipedema group based in Boston, and they're US, I think, a worldwide group, and they asked the same question. Well, what? Or they asked among each other. They said, "What was Dr. Perrin doing in the 1990s? How did he know about the central lymphatics?"
Yeah.
What, what, um, well, it all started with one patient, and I then it wasn't lymphatics I was looking at first of all. I was looking at the spine,
Mhm.
and it was a patient in 1989 who came in, who was a cyclist, who came in with um, spinal problem. There's a lot of long road cyclists, long distance road cyclists, or had sort of hunched over backs,
Yeah.
and they had
Yeah.
problems in their pelvis, and they had all these things. But so I was treating the team that he belonged to, but he hadn't been cycling for 7 years, but he still was a member, a card-carrying member of this team, which was called the Rally Banana team. There was a precursor to the Sky team, so any cycling enthusiasts have heard of the Sky. It was a world famous British team based in Manchester, where I
Okay.
live and work. So he came to me with spinal problems, but he also told me this was 1989, that he had ME. Now, in those days, it was called yuppie flu. That
Right.
a young upward professionals were coming down with this flu-like, but it was all in the mind, really. It was all because they were too much indoors looking over computers. So the basic instruction for people with ME in the 1980s was get out, do more. You need to do more exercise. You need to get
Mhm.
out and play. And this guy was told to do it, go back to cycling when he couldn't actually cycle at all now. But he was able to have some sort of job. It wasn't too severe like some of the patients I've seen. But so I started treating his spine and mechanics, and I treated the whole of his posture. And I always have used cranial techniques as part of my treatment as an osteopath. And his symptoms started to improve. Now, with my treatment, I've always done a lot of soft tissue work, working on the
Mhm.
fascia, working on the lymphatics, but I didn't sort of think too much about the lymphatics in those days. But I got him better. Within a few weeks, he was symptom free. In a few months, he was able to, go back to doing everything he wanted to do. So he was the one that sort of told me, "You found something nobody else has found. You've treated me with the spinal problems, and what you've done is helped my whole health and got me back to the way I should be." So he gave me a whole load of stuff about ME. I didn't know much about it in those days, but I started looking into it. And then it's been a road of discovery over the years. Bit by bit, I've put together the pieces. But the lymphatics came about when one of the patients had mastitis, had inflammation in her
Yeah.
breast tissue.
Yeah.
And she had help with the spine, but she still had a lot of heart problems and a lot of breathing problems with ME. So I started treating her mastitis, and I was taught by a physician many years ago that you can actually treat mastitis by basically massaging the toxins out of the breast tissue. So it was a bit avant-garde, but I
Yeah.
said, well, we can do this for the mastitis. We'll see what happens. So I started treating the lymphatic problems in the breast tissue and her chest, and her heart symptoms that she had with ME. All the palpitations went away. And I treated her spine as well. I did all the treatments I'd done on this patient, but did more on the lymphatics. And I noticed that she started getting better quite quickly. And within a few treatments of doing this, her all the other ME symptoms disappeared. And it was then that I realized that there must be a link. What
Mhm.
I'd done on the lymph had to be connected to what I'd done on the spine and all tied in. But I never realized that there was actually an anatomical link till further research. And this is when I found out about the work of Professor John Kinmonth in London, who was a professor who wrote a seminal book on the lymphatics and researched it in the 60s, 50s, and 60s and 70s. And he died in the 80s. So I never got to meet him. But his work was seminal in that he had worked out that the main thoracic duct of the lymph and the lymphatics themselves had sympathetic control.
Yeah.
And this was incredible that there was actually neurological control of the lymph. So I thought, well, if I'm treating the spine, and my original theory was by working on the thoracics, I'm helping the autonomic nervous system, the sympathetics. That must be it. I'm stimulating the lymphatics to work better. And then adding the drainage techniques that I was developing helped the lymph move better. But then I noticed that there was lumps and bumps in the patients that I couldn't work out where they were, what was causing them. They were mostly in the chest and the neck. And Kinmonth explained that he was a chest surgeon, and he discovered what was called varicose lymphatics.
Hmm.
backflows of lymph because the autonomic nerves in chronic illness wasn't working properly. This was his theory.
Yeah.
He had
Yeah.
no proof of that.
Right.
But I felt these varicose lymph, like varicose veins, but they were colorless because lymph in the surface of the skin, just under the skin, the subcutaneous fascia is colorless, the fluid. So they weren't like veins because they were not bluish or purplish, they were colorless. And so I couldn't see them, I could feel them. And then one day I got lucky and a patient came in with huge varicose megalymphatics on his chest. And I took the world's first photo of megalymphatics, as Kim had called it, but never could prove them because he saw them in surgery inside the body and he couldn't prove that they were lymphs. But this photograph went round the circuit and lectured on it. I remember one of the professors who I was lecturing to at the time, came over to me and said, well, "What equipment did you get to take this amazing image?" Camera.
Yeah.
It has to be
Just
some
a
really
simple,
expensive,
just a
yeah,
simple camera.
simple camera. Yeah, it was a good camera, but it's still a camera, just a
Right.
normal
Right.
camera. Um, and So we had proof that this varicose lymph existed. I could feel them, we could see them in some patients. And it was central to the main drainage of the lymph into the bloodstream underneath the collarbone. And that's where the main backflow was. So this was happening again and again and again. All the patients had this. And then when I was examining their chest, I noticed that there was a tenderness, which now is called Perrin's point, which I discovered this tenderness. So, sorry. So basically, I it was a sort of evolution of finding new things out all the time and trying different treatments. When I realized the lymph was involved, I used standard lymphatic drainage techniques that were really making some patients much worse. And I realized I had to go, rather than stimulate the lymph to work better, I had to work against this backflow that was obviously there.
Hmm.
And the backflow was controlled by the sympathetic nerves that were ultimately controlled by the brain. And that's when I started looking more and more in depth. And I did research at the University of Salford in the UK. And I was there 11 years doing research,
Wow.
postgrad research. And so I worked on a master's and then I upgraded to a PhD. And I got my doctorate in 2005 on the involvement of the autonomic nervous system and the lymphatic system, or uh, uh, causing chronic fatigue syndrome (ME). And
And can you
this
explain for anybody who doesn't know what ME stands for?
ME stands for myalgic encephalomyelitis.
Right.
The term was coined in the 1950s when there was an epidemic, a small epidemic of it in London in a hospital, the Royal Free Hospital.
And
And
of
after
course,
that,
post-war.
yeah. But the thing is that and nobody knows exactly why it started there. But
Right. Right.
it was there was questions that there's always conspiracy theories that there was some biological weapons being developed there at the time. Who
Oh,
knows?
okay.
But there's
But
always that.
just thinking about the autonomics, someone who lives
Yeah,
through wartime and bombing and all this stuff, of course their
yeah.
sympathetic response is going to go through the
Yeah,
roof.
but the interesting thing, Jeremy, is that there was this virus that went round the whole of the hospital in
Oh, interesting.
1955. And Melvin Ramsey was the doctor there that identified it. And this virus hit the nurses, hit the patients, and hit the doctors.
Hmm.
So, in an illness like a virus, if there's going to be a post-viral condition, it's probably going to affect the people who are the weakest, the patients.
Yeah.
However, it mostly affected the nurses because the nurses were physically lifting patients up, were
Yeah.
stressed
Yeah.
upon by the doctors and the patients in those days. And so they had the physical, they had also, they were immunologically challenged because they were seeing so many patients. And mentally, emotionally were challenged because of the way that they were stressed. and physically, I said, by lifting the patient. So they had the physical, chemical, emotional strains overloading their sympathetic nervous system more than anybody else.
Yeah.
And that's why I believe it was a group of nurses that got the ME,
Yeah.
not
Well,
the patients.
I would say I'm seeing a lot of it right now. I mean, I feel like we've just been through the same thing. The uptick in me treating health professionals, both doctors, nurses, mental health people over the
Yeah,
last 2 years has probably
yeah,
gone up in my practice at least 50% because of the
absolutely.
need.
Absolutely. I mean, long COVID is virtually ME rewritten.
Right.
There's a new paper just came out to I think today or yesterday from New York saying that long COVID, they've got biomarkers to show that the immune system's dysregulated.
Yeah.
And there's also that's David. Um, uh, I'm terrible at names. It'll come back to me. But he's a professor in Mount Sinai Hospital in New York, um, and his colleagues have just published this paper, so it's out there, and they've mentioned about the um, immune system being dysregulated and the hormonal system being dysregulated,
Yeah, of course.
and there's links to EBV, to Epstein-Barr virus. So it's
Interesting.
just ME
Yeah.
again and
Yeah.
again. This is all the same sort of research going on in the
And the Venn
1950s
diagram
and
of all
60s.
these things that we know now
Yeah,
of that
yeah,
probably are being influenced when this kind of stuff gets off track.
yeah. So there's a lot of similar illnesses around, but basically, what I reckon it was a buildup of toxins, inflammatory toxins, so neuroinflammation within the brain, that because of this backflow of lymph. So I then started looking at what I called the neurolymphatic system.
Hmm.
And I said there were other scientists out there in the 1940s. There was a guy called Speransky in Russia that did research on animals, and he showed that there was fluid, cerebrospinal fluid, draining through spaces around the blood vessels of the brain, the perivascular spaces.
Yes, I've heard about this.
And it drained into the lymphatics, or so we thought. We had no proof of it, but this was the theory. And there was a Helen Cern in America that did the same, looking at humans, saying that this was happening. And there was quite a few. There was Roy Weller, a professor in Southampton University in the UK, also looking at this. But they were looking at it as a theoretical model for anatomical, physiological. I was looking at actually in real time, looking at patients and looking at it as a clinical entity. And I said that ME is a clinical entity of this system becoming dysfunctional. And that was
Hmm.
the basic hypothesis of my whole research. So if you go back in time to this was the 1990s, and in 2005 I finished. I started in 94, finished in 2005, two research projects, working at the university, as well as seeing patients in clinic. And my PhD, the Salford gave me a doctorate in the field of ME, which really wasn't believed to be an actual illness by a lot of
Right, right.
my theory was it was the drainage of the brain going in the wrong direction, causing the buildup of toxins. So the drainage of the brain had not been proven then at all.
Yeah.
It was 2005. It was actually proven to exist in the human in 2017, 12 years later.
Right, right. That's how new it
So
is.
yeah, that's how new it is. The lymphatic system has been proven to exist in the human only since 2017. There's a lovely paper came out in America, and it was shown to exist in animals in 2012, 7 years after my thesis was published. So I had to wait 7 years before they actually proved that this perivascular space that I talked about in my hypothesis was actually draining into lymphatics. That was in mice, but then it took time before they worked out scanning techniques that they could do safely on humans to show this drainage existed in humans. So we now know the lymphatic system of the brain, the neurolymphatic system, coined by the Rochester University in New York group. They coined it the lymphatic system, the lymphatic system of the glial cells.
Yeah.
So that's why it's called the lymphatics. So they coined it that term, and that stuck. And but this was the system I was saying was going wrong, and not just in ME, in fibromyalgia, in Alzheimer's, probably almost certainly a lot of research has been done on amyloid beta, which builds up and causes Alzheimer's. So the same thing. And there's many different neurological conditions that have a definite buildup of protein molecules and large molecules like for instance, Creutzfeldt-Jakob disease, as prions building up.
Yeah.
Now, why large molecules? Because that's what the lymphatics are there for, to drain away the macromolecules. The small molecules can go through the blood, but the macromolecules can't. And the thing is that for years, the whole of science, why were they against my work to begin with? And why was it so radical? Because officially, there was no drainage of the brain. When I was doing all my thesis from the beginning to end, there was officially no drainage of the brain into lymphatics because it didn't need one, because we have the blood. And the blood could cope with any small molecules. Large molecules officially couldn't get into the blood because there's a barrier.
Yeah.
The blood-brain barrier.
Yeah.
So this blood-brain barrier basically was the stumbling block in my whole theory. But I said, the blood-brain barrier is not a very good barrier. And we know this for sure. And I came up with that whole concept, and I thought, well, it's obvious to everyone that it can't do the job that it should do. Because every second of every day, huge molecules enter the brain. Yeah. And I couldn't work out why nobody else realized that, And the answer was hormones. Hormones are huge molecules. And they're controlled by the hypothalamus in the brain, which also has a major control over the autonomics as well. So I thought that's the key, the hypothalamus. And the hypothalamus, as we know, monitors all the hormones and controls it by a mechanism called biofeedback. So let's take the example I always give is insulin. Insulin's a very large molecule.
Yeah.
Small molecules like water can get through the blood-brain barrier, and water's 18 Daltons large, Dalton being the measurement of a molecule, named after, by the way, John Dalton from Manchester.
Yeah.
I wave the Manchester flag. So there's a nice John Dalton Street in the centre of Manchester if you ever come to visit.
Oh, cool.
So 18 Daltons is the size of a water molecule, and that can get through. But huge molecules like hormones, like insulin, that's 5,808 Daltons. It's a massive polypeptide molecule. How can it possibly get through a barrier that's meant to stop any large molecules? And we now know that our 7 circumventricular organs in the brain, 7 areas where there's basically not much of a barrier at all. So large hormones can get in, 2 in the hypothalamus, there's the pituitary gland, there's the pineal gland, to allow hormones to get through, and also electrolytes, salts and sugars to get through as well.
Yeah.
So these areas are weaknesses that allow large molecules, huge molecules in, so therefore large toxins can get in. And spike proteins of viruses can get in, and all sorts of
my daughter had meningitis at 12 days old. Really? Bacterial group B strep, which I was just learning about because my wife tested group B positive when we were going into delivery. But she had a C-section and still, broke the blood-brain barrier and had.
How was she? Was she okay?
She was fine, and luckily, I happened to treat newborns, so.
You did cranial.
So with cranial work, I do a lot of work around lactation support. So.
Well, see, the cranial. What I've found is that there were 5 physical signs of ME, and fibromyalgia as well. And now we're seeing it in long COVID, developing into full-blown ME. And the signs were there's varicose lymph, were spinal problems. They all had spinal problems, the mid-thoracics
Mhm.
to upper thoracic spine, and that would affect the sympathetic, but also affect the drainage in the spine as well. The blood-brain barrier doesn't stop at the brain; it goes
Right.
right down the spine, and this is where they're doing all this research on the brain, but it's the spine as well.
Yeah.
And when there's spinal problems and cranial problems from birth or from trauma or from developmental problems genetically sometimes,
Yeah.
you see this, you see it in families. And therefore, just like a person can look like their parents by the genetic makeup of their facial bones, the cranial bones could be genetically exactly the same as well.
Right.
And therefore, if there's an anomaly, it could affect the drainage of the brain.
So,
And it's
so,
the
so, so
drainage
you
of,
see that within a full family having ME issues?
yeah, you see a whole, yeah. In
Ah,
fact, there's research done by a chap called Jesus Castro in Barcelona who's showed 15% of all ME CFS patients, CFS being chronic fatigue syndrome, which is the umbrella term for all this. And patients prefer the name ME. Doctors often use the term CFS, but we use ME CFS now. So Jesus and his group in Barcelona did the research and showed 15% of all ME/CFS is familial. 15%.
interesting.
So we see sometimes whole families with it.
Yeah.
Mother, I had years ago, I had a mother and three of her sons had ME, and they were going to take them away and put them into psychiatric care and the mother separate from the children because they reckon she had in those days what they used to call Munchausen's disease by proxy. Now they call it fictitious illness syndrome. They reckon that the mother had projected her illness onto her children. They said
Ah,
nobody can have three children all in the same family, all with ME, but they did,
yeah.
all
Yeah.
severe.
Yeah.
So it was a big tug. We had a big battle on our hands against the social workers, but myself and a few doctors, we battled and we won the case, and they left the kids alone. But they would have taken them away, and they were doing this quite a lot in the 80s and 90s for ME
Is that
patients.
right?
It still happens now, unbelievably in some parts of the world. So we found this. So spinal problems. Then I found these varicose lymphatics in the chest and the neck. We find, and then this point that I discovered, Perrin's point, which is to do with the sympathetics firing off from the thoracic duct, the main duct of the lymph that turns to the left side around that top part of the chest, and also it, besides the thoracic duct, there's irritation of the cardiac plexus, a big bundle of sympathetic nerves
Yeah.
that controls the heart. And this, why a lot of patients with ME get POTS or get orthostatic intolerance, get
Yeah.
palpitations, tachycardia. And this affects their heart's control rather than there's actually anything wrong with the heart. But the sympathetic nerves fire off. And when they come to the surface, they fire off to sensory nerves. And there's a crossover between sensory and sympathetics. Everybody's heard of synapses, the
Right.
synaptic cleft. So everybody's heard of synapses, but very few people I've lectured to over the years, all around the world, have heard of epiapses. I don't know if you have, Jeremy.
I've heard the term, but explain it to me.
Well, epiapses is, say this is a somatic nerve, a
Yeah.
sensory nerve, and this is the diameter of a sympathetic nerve, my finger.
Okay.
And if they're very close together, which they are very in the surface of the body, deep in, sympathetic nerves go alongside blood vessels to protect them, but near the surface, they'll go alongside somatic nerves to
Okay.
protect them. And there's a crossover between the actual axons. So between the actual cell, there's actually a crossover
Is
of
that apoptosis as well? The same thing or
well,
different?
apoptosis is different, but this is actually signals, electronic
Okay.
signals, similar to what you have in the synapses from signals going via neurochemicals, and you've got signals going from because it's basically almost like electricity in the nerves.
Right. Right.
You've got the same electromagnetic fields and messages going from one small sympathetic nerve to a somatic nerve and vice versa.
Okay.
So when there's irritation of the sympathetics in this area, it can cause these apapses to
Okay.
fire off and cause the somatic nerves to fire off, causing pain, sensation, all different symptoms that you don't usually expect from sympathetic nerves. And this causes an irritation of the somatic whole bundle of somatic nerves, of sensory nerves in this area. So when you have the two networks of sensory nerves from the cardiac plexus irritation and from the thoracic duct irritation coming together, you get this point slightly above the left nipple area on the left, which is tender in all ME patients. And we
Yeah.
see this well, fibromyalgia, you have pain everywhere, but with ME, we see this, and we're seeing this a lot with the long COVID as they get more and more ingrained in the body. This starts becoming irritated.
Is
Then we find
is that a, sorry, is
yeah,
that
sorry.
is that a signaling of some sort that's going on, or is that part of the
Yeah,
backup?
no, it's a signaling, but it's errant. It's due to bad sympathetic tone. It's due to irritation rather than a signaling that should happen in health.
Right, right.
So it's firing off, errant
Danger
response
signals,
causing,
basically.
yeah, basically danger. So that's what the sympathetics do. It's
Right.
saying this is not right, and it's firing off, but it's
And
hitting the
then the
central.
endocrine system over responds, probably, right?
And then there's a lot of chemical changes going on, but that causes this tenderness that was now known as Perrin's point because I
Okay.
discovered it. So this is not an anatomical point. It's just beneath the surface. It's not deep into the rib cage. It's a superficial and is tender. And in worst cases, it's more sensitive, more sensitive and more tender. And then we have a tenderness in the celiac plexus area, which is the solar plexus, which is beneath. If I can show you on my it's
Sure.
around here,
Yeah, yeah.
and this is a tenderness that we saw, and we can explain that very easily. Boxers, they can knock you out in the head or knock you out in the body blow into the solar plexus. And this is a big bundle of sympathetic nerves,
Mm-hmm.
and if the sympathetics are all irritated, especially when you have a lot of ME patients and fibromyalgia patients, and now we see long COVID patients have irritable bowel and problems at IBS. They get a lot of problems. A lot of women are getting problems like polycystic ovaries in combination with their long COVID or with their ME, and there's a lot of interaction. And when you have a lot of bowel problems or abdominal problems, whether it's gastrointestinal or genitourinary, that irritates the nerves that go into the solar plexus. And it's the very bottom of the thoracic duct. So when it's pumping backwards, it will pump toxins into this area.
Mm-hmm.
So what happens is this area becomes very tender and inflamed. Often you feel the heat. And there's heat in the spine, by the way, as well, we can feel. There's a lot of inflammation usually in the spine, not always, but mostly. And then we feel the cranial rhythm. And the cranial rhythm is the neurolymphatic drainage. I wrote a paper in 2007 in the American Journal, so the Journal of the American Osteopathic Association in 2007. I think it was June 2007. In this paper, I showed my theory of what the cranial rhythmic impulse was. Because there's all different, if you've done the ledger course,
Right.
there's all different theories to what the cranial rhythm is. And I said, it's obvious what it is. It's all based on physics. We don't need to go into
absolutely.
any
I mean, it's a saline tide. It's pumping a system. It's
the fluid in the brain. And I'll ask this to you, Jeremy. And if you get this wrong, don't be embarrassed at all. You can delete it from the video. But I asked this question to every person who's studied cranial osteopathy and all the osteopaths and all the cranial sacral therapists that I've trained. I always ask them the same question. Very few of them, unless they've read my book from cover to cover or know my work inside out, will get it right. So I'm asking you the same question. What the ventricles, the third and fourth ventricle, it has between it, there's an aqueduct of Sylvian, the aqueduct, yeah?
Hmm.
the fluid. And the fluid, cerebrospinal fluid, goes from the fourth to the third, and it goes to the lateral ventricles and goes back. So if or it goes the other way really, so into the fourth ventricle and then down the spine, and then it's a two-way effect. But if you have cerebrospinal fluid moving, if you were able to actually, well, we know it does move, in the brain itself, if you're able to palpate that aqueduct, what would be the beats per minute of that rhythm that you were feeling within the brain?
Well, I'm a musician, so this is a good question for me. Let's see. Beats per minute. Um, so I mean, my feeling is that, and it probably varies with each person, but five is it about 5 to 7 seconds per cycle, or is that not
Yeah, this
right?
is, well, no. A lot of people will say 5, 7, some up to 12. I mean, there's 8 to 12 was the original
Eight to
Sutherland
12.
discussion of the cranial rhythm.
Yeah.
And then there's all different variants of that. But everyone that, and I love this question because everybody says that and they're completely out of the ballpark, completely
So it's
wrong.
not eight. I was going to say 8 to 10.
Nowhere near. And we know neuroscience knows exactly what it is. We don't need Sutherland, we don't need Upledger, we don't need all the great cranial osteopaths, going right back to Andrew Taylor Still, the founder of osteopathy, who actually started cranial. Sutherland took it to the next level and made it into a science,
Yeah.
and
Yeah.
Upledger spread it to the world. But they were talking about the cranial rhythmic impulse, which is not the same as
Oh,
cerebrospinal
okay.
fluid
I see what you're
in the
saying.
brain.
Yeah. Yeah.
Cerebrospinal fluid, but the thing is not taught. It's never taught. I was never taught this. Cerebrospinal fluid is produced by the blood in the choroid
Choroid
plexus, and it
plexus.
goes
Yeah.
around the brain and down the spine and goes back up into the brain and into the venous sinuses. Yeah,
Yeah.
back into the blood. So it starts with a pumping of 50 to 100 beats a minute, and it finishes 50 to 100 beats a minute because that's the cardiac rhythm.
Yeah.
And it follows the cardiac rhythm within the brain and the spine. It's only when it comes out from there,
That it
now we know,
pulses.
into the lymphatics. And John Kinmont, and a chap called Browse discovered that the thoracic duct had a beat of 4 beats a minute.
I
Very
was going to say I've
slow,
heard four before, and I'm not sure.
very slow. The thoracic duct moves a very slow 4 beats a minute.
Okay.
But when you have something that's going 50 to 100 beats a minute, draining into something that's pumping up 4 beats a minute, physics dictates what happens next.
So it's
You
interesting.
have,
One of
yeah,
my,
sorry,
I think it was maybe the second course that I took in through Upledger.
yeah,
I think we were covering some of this stuff, and I asked the teacher at the time if just, I mean, my instinct was that somehow naturally all rhythms must sync up within time.
yeah,
And so I'm guessing that if we're talking 60 beats per minute with the heart rate or whatever,
yeah.
that's got to be like, quartered or something, right? By that
Yeah, well, what
pulse.
happens is when you have two pulses, and it's called the interference wave, what forms in physics. And you don't need to be a physicist to understand it. It's
Yeah.
part way between the two. So this comes to a beat of around 8 to 12 beats a minute, which is what Sutherland discovered as what he called the cranial rhythm or the
Yeah.
cranial rhythmic impulse. And that's a result of this drainage. So I thought this is the proof. The cranial rhythm is the proof of this drainage occurring because this is what we're feeling. And every ME patient had a disturbed rhythm, everyone.
Yeah, that
And
makes sense.
every long COVID patient has a disturbed
Yeah.
rhythm. Every fibromyalgia patient has a disturbed rhythm. And we see this in many diseases, and it's because this neurolymphatic drainage that we now know exists isn't working correctly. It's working the wrong way and dysfunction. So it's all over the place, or it's sometimes very rigid.
Yeah.
And this is what we feel. And when we're stimulating the cranial rhythm, when I do treatment now, I always add lymph drainage to it because it's part of it. That's my thesis,
Yeah.
and that's what was published in a paper in 2007 in America. So this explains everything. You don't need to be a physicist to understand what I've just said. You just have been somebody who's been to a beach, and most people in the world have been to a beach. You see
Yeah.
a big wave coming in, small wave going out, they crash together, and they produce a third wave. That's the
Okay.
interference
That's
wave,
the
and
third wave. Okay.
the same in the human body. So this what causes what we call the cranial rhythm,
Okay.
the voluntary mechanism. There are other rhythms that are talked about, that's different tides, but that's related to positive breathing and other integral rhythms in the brain. And we're not going to bore your listeners about
Right.
Traub-Heving-Mayer rhythms and autonomic rhythms in the brain, but there's other rhythms going on there. But the fundamental root to what the cranial rhythm is this. I'm absolutely convinced of it because all the patients that had problems with the drainage had a disturbed rhythm. Once we got the rhythm working and we got the lymph working and health was restored, you could feel a nice, healthy, vibrant, I call it like
So
a
this is, yes.
symphony.
So that this is my
And
next question then for you is, so obviously within our allopathic care system, there's not a lot that can be done with these kinds of things. So I'm assuming that you were testing and trying different kinds of things with people for years, intuiting the
yeah,
fact that there was a disturbance in the way you could feel, the
yeah,
rhythmic movement through a
yeah,
system. And we know that, there are probably things you can sort of force in a system, or changes you can force, electrically through medication, but it doesn't really solve these
no.
distortions in the way there's restriction around areas
Yeah,
or back pressures
absolutely.
or whatever, right?
So I was the one that was saying it's a biomechanical disorder,
Right,
and
right.
the antagonism and the the amount of people out there who are against this is immense. Because let's face it, I hate to say this, but big pharma aren't going to be very happy about me.
Right.
Because I found a mechanical problem that can be treated biomechanically and
Yeah.
get people better without drugs.
Yeah. My challenge to people who call us quacks is that I dare you to try to make a career out of craniosacral therapy or cranial osteopathy. It's just not an
Well,
easy road.
there's a reason. Research I've been doing now 34 years clinical
Yeah. Yeah.
research, and I've the money, the amount I got, I think £100 from the British osteopathic profession in all those years, and nothing
I
from the
that
government.
does not surprise me.
That is all I've been given from the professions. All the money that I needed to do the research I've done has been private donations from grateful patients or
Oh,
people who
wow.
understand what I'm doing.
Yeah.
And this is what we've done over the years. We've had a charity trust that's funded all the research. Otherwise, I couldn't have done what I've done.
Yeah.
And it's so I'm very grateful to all those people over the years and try to give something back and help them. And we're helping people, and we're helping a lot of long COVID patients now. I wrote the paper. I always say this. It's quite humorous, and my wife's not here at the moment, so she can't hear.
Yeah.
But I wrote the paper on long COVID, the first paper on it, and how it's going to affect the brain.
Oh,
On
I'd like to
March
read it. If we could share it, it'd
it's
be
open
great.
access. Yeah, I wrote this on March the 11th, 2020, the
Mm.
day World Health Organization announced the worldwide pandemic, and that was my anniversary, Jeremy. So normal people don't spend their anniversary staying up all night writing a
You're right,
paper.
right.
My wife's had to cope with a lot, and I stayed up all night writing this paper. I said it's important we get this out. And it was called Into the Looking Glass, Post-COVID-19 Post-Viral Syndrome. And it's available. It was in the Journal of Medical Hypotheses. It's open access, so you'll be able to get it there.
Okay.
I don't know what citations it got, but you look at Google Scholar. Last time we looked at it, it had 257 citations. and that's since it was published in June 2020. I wrote it on March and it was published in June. So in that time, it's had, everybody's now realized what I was saying is actually happening. It is affecting the brain and it's causing the same symptoms as ME. And we know why, because of this backflow of lymph into the main passageway of drainage in the head is the cribriform plate in the olfactory drainage. So you've got the olfactory nerves going through the cribriform plate, which is in the bone, the ethmoid bone, which is above the nasal bone in the skull, in the cranium. And it's in that ethmoid bone, you've got the cribriform plate, and through the cribriform plate, there's perforations which allow drainage. It's explained in my book. This book.
I just had this book. That's great. Yeah, well, absolutely. And I'll make sure there's a link up. I would like to get a copy before you come to Minneapolis too.
Yeah, absolutely.
But I was just having this conversation with on the podcast a couple episodes ago with a guy who's does functional medicine, naturopathic work, and is a chiropractor. And I was telling him about the fact that I don't know why exactly, but I started getting people sent to me through therapists, through talk therapists for managing anxiety because they had loss of taste and smell, and that was bringing up a lot for them. And
and they also had anxiety because it drains through the cribriform into the prefrontal cortex first. So you get brain fog. It then goes deeper into the mid part of the brain. What Iliffe and co. discovered in Rochester University when they first discovered the lymphatics in mice, they found when they stopped it draining, it caused a buildup in the limbic system of the brain, in the mid part of the brain, the thalamus, the basal ganglia. And these areas are very crucial in the pathophysiology of ME and fibromyalgia. They control pain. So for fibromyalgia, they're very important. So when they get damaged by toxins building up there, it causes that. But this is the limbic system, the emotional side of your brain. So what we saw and the hypothalamus is just around there as well. So the hypothalamus is in the hypothalamus, you've got the supraorbital nucleus, which is a nucleus that is the center for fever, and this nucleus in the hypothalamus sends messages that stimulates fever in the body. So it affects temperature regulation and it causes all the symptoms of fever. And this is what we were seeing. We were seeing anosmia or loss of smell, or the smell was affected and taste. And then it ended up with fever, and those were and brain fog. And these were the first symptoms of COVID. And then continued on with long COVID because if the drainage wasn't working or working the wrong way, it just kept on building up cytokines, which are the inflammatory toxins that are built up in the infection. And these are used in the immune system. Cytokines are signaling molecules, and they're there to protect you. But if they've got to drain away, and there was massive amount of cytokines, interleukins, interferons building up with COVID and with lots of infections, and this leads to this post-viral syndrome. So we said all about this in my paper I wrote, and then my colleagues sort of edited it a bit, and we published it in June 2020. So I said you can see that all the things we said then has happened. And when I look back at my work in ME, all the things I wrote about in my thesis have been proven.
Well, I wish I would have read it back then, because I was getting people coming in who, I was doing one treatment, and my instinct was to, of course, work around ethmoid. But I wasn't sure of, so what was happening was people would come back to me, a week later and say, I've got most of my, taste and smell back.
Yeah.
And I wasn't promising anything with that. I was more
Yeah.
thinking about the fact that, like, let's see if we can shift in, an autonomic
Yeah.
response, and
Yeah.
maybe there's some kind of, neurological, loop that also gets stuck once it kind of gets off track. But I didn't think about it from that perspective.
But you were opening up the passage and allowing the drainage to occur.
Yeah.
And, keeping right up to date, there's so much more in the last couple of years. Last year, in 2023, has been a massive year for discoveries of what's going on with the drainage. Because we now know that, the subarachnoid space. I don't know if
Hmm.
your listeners
Yeah.
how how much they're anatomically if they're quite anatomically attuned. But in the brain, you've got this subarachnoid space filled with cerebrospinal fluid. Now, what we used to think was the techniques that I've developed to drain off the toxins using cranial and lymphatic techniques, directed, not standard techniques, but directed against this backflow. That's the key.
Hmm.
The key of the Perrin technique, which I developed, is a concertina or accordion effect, pushing up and pushing down, creating a pressure to push into the main drainage of the lymph into the subclavian veins, into the venous angles just underneath the collarbone. And it's this pressure that we create by massage techniques and by cranial
Yeah.
that leads to a drainage in the right direction. And then eventually it drains off the toxins. And this leads to the next effect when we create this pressure, the siphon effect, which allows in hydrodynamics. Siphon
Yeah.
effect is when you create a pressure differential and it continues on. So if you
Yeah.
suck
Yeah.
up a tube, it continues
Right.
on.
Once
So
it starts.
so that's what we do, and eventually it drains off all the toxins. So this is what we do, but what we thought was that healthy cerebrospinal fluid is replaced from the subarachnoid space into the brain and into the tissues, and eventually health is restored by the good stuff replacing the bad stuff. It's not as straightforward as that
I kind of figured.
because
Yeah.
because we are struggling with some patients. Some patients take a long time, and some patients, every time we drain off the toxins, they come back the next week and new toxins seem to be there. And
Right.
as much as we go, it's a very slow progress for a lot of patients, and some patients you're really struggling.
Because
Why?
it's not just that one system, right? There's a lot of systems that need to sync up together to start, functioning properly.
Yes, that was always the thing. That I mean, it's not just the ME; it's the results of the ME for many years. It's a
Yeah.
chronic illness.
Right. Exactly.
But this year we discovered a really valid reason for this. Even when there's nothing else going wrong with some patients, it's just taking a long time. Why? Because the tissue, a membrane called SLIM, was discovered. I don't know if you heard of the SLIM.
No.
SYM. Subarachnoid lymphatic-like membrane.
Okay.
A membrane dividing the subarachnoid space into two areas. In the outside is where the lymphatics drain into.
Hmm.
So the outside of this slim is full of toxins, and the inside is the healthy stuff that replaces it.
So is it like
And
another semi-permeable membrane that things
yeah,
more can get
yeah,
through?
yeah, small molecules can get through, so the bad stuff doesn't go in. But if there's damage, it's only one cell thick in most places,
Okay.
this
Okay.
slim. And if there's damage, trauma to the head in any way from birth or anywhere after that,
Yeah.
or trauma to the spine, because subarachnoid space goes right down to the second sacral segment, all the way down the spine.
Yeah.
So the slim is almost certainly going there as well. And it's so small, nobody knew it was there until the new scanning.
Yeah.
And in death, it dissolves so that you couldn't see it in post-mortem. And think of how many people have had lumbar punctures, have had spinal taps
Oh
over the
yeah.
years,
Yeah.
and afterwards they've suffered really badly
I've worked with a
because
lot of
the
people. Yeah.
because the needle has gone through this slim, and the doctors didn't even know it was there to damage.
Yeah.
put it into the subarachnoid space. How many women have had epidurals by accident? It's gone into the subarachnoid space and there's a leak after epidurals when they're having babies or epidurals sometimes in surgery.
Mhm.
But that that's because they've gone a bit too far into the subarachnoid space. And so don't worry, it will heal. But what happens if they've damaged the slim at the same time? It might not heal. And and then if there's many traumas over the years, it could affect the slim more and more in the head and the spine, which causes toxins when they come out to go back through these spaces now created by the damage into the brain. So as we drain off, more toxins are continuing to come back in.
And it's got to make you wonder how many things we have still yet to discover.
Yeah. And that brings us to the very latest, Jeremy, because this is going to blow your socks off.
I love it.
There's a scientist. Well, he's not a scientist. He was like me, a practitioner doing his job. He was his name is Joel Pesser, and he's a retired orofacial maxillary plastic surgeon
Mhm.
in Texas. And he noticed all the way through his career, or near the end of his career, whatever, he noticed there were channels in the neck when he was operating,
Mhm.
which had fluid in, and he had no idea what they were. They weren't in the anatomy textbook. They were next to the blood vessels going down
Mhm.
into the subclavian veins, but he didn't know where they came from, and he didn't know what the fluid was either in the channels. It's clear fluid, and he thought, there's not lymphatics. We know where the lymphatics are in the neck, and these were definitely not lymphatic vessels, just basically just canals. So in his retirement, Dr. Pesser has got together with an anatomist, and they got a few cadavers and they injected these spaces that he opened up, and and it's not microscopic. You could see them with a naked eye with a magnifying glass, but
Mm.
magnified, but you could see it quite clearly, these channels. And he injected these channels with a dye, and he saw the dye went right into the subarachnoid space. So these
Interesting.
are extra channels on top of the lymphatics,
Yep.
on top of the blood that nobody ever knew existed.
And is that
And all
is
the
that its own
anatomy,
system then?
it's just relies on gravity. So very severe patients with ME and fibromyalgia and
Yeah.
long COVID now,
Yeah.
they're being assessed that they're getting better by sitting up. And I said at a conference just now, I was just at Stony Brook University for the big international conference on ME. And I said to some of my colleagues, I said, well, it's not that sitting up is a sign that they're getting better. By sitting up, allowing gravity
Yeah.
allows these new channels, well, they're not new, they've been there forever, but the channels that we now know, these canals, he calls them the canalicular system, he has
Mhm.
termed it, the cerebrospinal canalicular system, draining off the fluid in cerebrospinal fluid from the brain into there by pure, simple gravity. And when we do our massage techniques that I
Yeah.
teach for the drainage, it's helping the lymphatics, but it's also helping these canals that are not
And
moving.
is that does it look like it's sort of like draining into something that's also related to like the
It's draining
fibromyalgia,
it straight, it's
the
draining straight into the blood vessels.
oh, into the blood
So it's
vessels.
a
I
direct
was wondering
link.
if it was a
So it's a direct
fascial.
link from the brain into the blood vessels.
Okay.
Unbelievable.
But it kind of
Unbelievable.
makes sense with POTS then, right?
It makes sense with a lot of things. It
Yeah.
makes sense with why the massage down is so important.
Yeah. Yeah.
And we know that the lymphatic system has now been shown to, the pumping mechanism and the drainage of the brain is so shown to happen during delta wave sleep, during deep relaxing sleep. And the deep sleep is restorative because it drains off the toxins. We now know this. This is the work in Rochester University where they showed this, that there was during delta wave, the mice drained off the toxins. And this is where ME patients don't get delta wave. Fibromyalgia patients have little
Mm,
delta wave. And long COVID now, that sleep is a big problem and they're
yeah.
just not getting a delta waves. So they're not draining off the toxins. They wake up the next morning feeling shattered.
Yeah.
And during the day, some delta wave occurs during the day, making them feel tired, but also making some of the toxins drain away, causing them to feel nauseous and sick. And that's all because the drainage is working the wrong time. It should be working when you're asleep. But during the day, when you get up, it helps drain off anything that hasn't drained away. If you get up, if you're
Yeah.
lying there in bed all day doing nothing, not going anywhere.
Right. Right.
So this explains so much more of
And
what I
I've worked with
know.
so many patients like that where they have these terrible mornings, and then sometime around noon they have this big uptick once they've kind of gotten up and started moving, and then usually there's another crash later
Yeah,
on.
yeah, yeah, yeah. So we're understanding much, much more, and it all fits the model that I sort of worked on all those years ago, and it's nice to have science back up what I've
I
been
know
saying for
our
years.
instincts. I know. So for anybody who's struggling with chronic fatigue, or um, what kinds of things can we obviously I mean, it's always been my instinct that some kind of manual therapy, especially around this head and neck area, is just
Yeah,
such a
yeah,
crucial
yeah.
junction as far as lymphatics are concerned,
Yeah.
CSF.
Well, they can do it themselves at home. It's not as good. We're
Right,
just
right.
finishing a study in the UK. There's the NHS are actually looking into my work now with long COVID.
Yeah.
So they're doing a study that when I was in America last, and I've been 4 times this year already for conferences, and when I was there, I in Stony Brook, I was saying, the difference between American medicine and British medicine is basically in American medicine, it's how much money we can make.
Hmm.
In British medicine, it's how much money we can save uh, because of their national health service. It's all about saving.
Right,
And we've
right.
got a self massage and exercise routine that we're going to make public very shortly.
Yeah,
It's this research is still going on, so I can't talk too much about the
yeah,
research. I don't know a lot of it myself, but it's going on and it's going to be finished in November, where we're giving patients self-massage exercises that are in my book, that I
yeah,
teach in my courses, and they can do exercises to get the spine working better. They can do self-massage to help the neurolymphatic system working better, and they can use certain techniques to help the cranial. But then the best thing is to go to somebody who's trained in my techniques. And in your neck of the woods, there's Ruby Tam, who's
yeah,
a wonderful physician, and she's got the world's first free ME clinics, but funded by charity.
yeah.
And she's been doing my work
It's
since I
amazing.
trained her, and she's had some amazing results. And I don't know if I can share the story, but one I don't know if she's shared with you, but one of her patients was at the end of his tether, and he just wanted to give up everything, and he wanted to give up his life. And
Hmm.
he saw an interview like we're doing now with me and another medical journalist online, and it made sense to him for the first time. Just so he was going to end it that day, but he got in touch with Ruby and has been having the Perrin Technique treatment and is on the mend now.
Yeah,
And when
that's
I
amazing.
come
She
next,
told me, I talked to her a couple weeks ago actually, and she
and
told me about it.
when I know, amazing. So when I come to Minnesota next year, we're having a meet and greet session, and I'm hoping to meet my star patient.
That's great. That's so cool.
But it's great when Ruby said, but we do, I've been treating thousands of patients for 34 years, and we've helped a lot of patients. We can't help everybody, and there's always going to be some that just the damage is too much. So I say, we've tried everything, but there's too much sort of um, it's not the ME itself, it's the results of having the ME. It's
Right.
all the side
The
effects.
physiological long-term effects.
Yeah, and it's all that the other damage in the physiology and in the anatomy that sometimes you just can't repair. But we keep most people going in the right direction,
Yeah.
and sometimes we get to a certain point and we just have to keep them in that area,
Right.
which is
And
much better than they both.
stop the downslide if nothing else.
Yeah, and and it keeps them alive and kicking. And some
Yeah.
people we get much better, and some patients we get completely symptom free. But
Right.
with ME, because it affects so many different areas of the body, it affects the whole metabolism, because the autonomics control that hypothalamus controls and the hormones, so they control the metabolism. So it affects everything. So there's going to be collateral damage to having ME,
Yeah.
which is something that sometimes we can't help, and there've got to be other things. The basic tenet in my new books that I've written in the last couple of years were basically what I call the jigsaw puzzle analogy. For ME, CFS, for fibromyalgia, and for long COVID, this works. And the analogy I use, the jigsaw puzzle analogy, is based on the fact that if you build a jigsaw puzzle, you build the corners first, then the edge pieces, and then the middle.
Uh-huh.
The corners with ME, fibromyalgia, and long COVID is getting the patient to rest more. They need to
Yeah.
rest.
Yeah.
And it's got to be good rest. Sometimes they can't, so they've got to relax. So that's the second corner. So just resting, saying, I'm resting, is not good. You've got to
Yeah.
rest and relax. And some people find that very difficult. So to help, you should learn how to meditate. And meditation is so important. Thinking of the now, thinking of the present,
Yeah.
mindfulness. There's loads of different meditation tapes and courses people can go online and in real. And then the last one is the most important. That's pacing. Half of what you feel capable of doing.
Yeah.
That's the golden rule in my book.
Right.
And the thing with pacing is that for years, doctors were saying with ME patients, push, push, push. The early patients I told you about. And they just carried on pushing and pushing and getting more and more ill. What I've told the patients for years, saying half of what you feel capable of doing, pace. I once
Yeah.
gave this at a
Yeah.
lecture, a conference, and a doctor said to me, does pacing mean walking very fast up and down a corridor? I said, no, not that type of pacing.
Yeah.
So it's amazing how,
Well,
so
it's similar to what I sort of coach too, because the rest, like, I mean, I also deal with a lot of orthopedic challenges and back problems and these
yeah,
kinds of things,
it's
and
so important.
muscle spasms, and the usually the trick to getting out of those things is rest, but not too much rest. You really have to be some movement helps to get all these
Yeah,
different systems to
absolutely. The
go,
cure for this ill is not to sit still,
and that's the
but you
pace.
have a period of resting during the day
Yeah.
where you just stop everything, and that's where the chillax, the resting and relaxing, and meditate. And then the pacing is always whatever you do. Think, can I do double? And the answer always has to be unequivocally yes. So that's not just double physical activity, it's mental activity, it's watching television, it's speaking to people on
Yeah, that's true.
Zoom, everything. Whatever you feel you're capable of doing, you should do half.
Yeah.
And then the next stage is the edge pieces. And the edge pieces is is my technique, the Perrin technique. Looking at the neurolymphatic system, looking at the mechanics of the spine and the cranium and the body,
Yeah.
getting the biomechanical problems sorted out. And then when the autonomic nervous system is starting to work better because there's less toxins in the brain, then we look at other things like that's the see in the sky part of the jigsaw puzzle.
Mhm.
That's the talk therapies. That's the additives. Sorry, not additives, the supplements.
Supplements. Yeah.
Supplements. That's the if necessary, pharma as well. And necessary some drugs are necessary. But that's the sea in the sky. But
And I,
first,
I
we
I
need to
like this
get the
analogy
corners.
too, because those jigsaw pieces, those ones that are similar colored, you have to try, you know, a lot of them before you find the ones that fit
Yeah,
together too.
yeah, absolutely. And some patients are 100-piece jigsaw puzzles, and some patients are 1,000-piece jigsaw puzzles.
Exactly.
And you can do it without doing the corners first and the edge piece, but it's much more
Yeah.
difficult.
Yeah.
And also, there was one patient that said she's a baked bean jigsaw puzzle. I don't know if you've seen that one. That's every piece is just a piece, some baked beans in it, or it's the hardest jigsaw puzzle in the world.
Right.
She
Right.
says I'm the baked bean jigsaw puzzle,
Yeah.
and sometimes it's much harder than others. So that's why some patients get better much quicker than others. But but we never give up, and we try our best to help most, and we do, and that's why I've been doing this for 34 years, and
Yeah.
hopefully I'll be here in 34 years' time.
And that's why I wanted to talk to you too, is because I one of the things that the reasons I'm doing these episodes is because there are a lot of people in hopeless places, or to sort of challenge the traditional approaches that just aren't working, and know that there are sometimes more subtle ways, and sometimes, like I was saying, I didn't expect these issues with taste and smell to resolve so quickly. I've
Yeah,
seen I've
yeah,
seen similar things with allergies. I'll get a kid who has just terrible allergies, and
yeah,
I'm sure it's because I'm getting their lymphatic system moving and
yeah,
their glymphatic
absolutely.
system.
Absolutely. But if you get the lymphatics and the cranial together, that's working
Yeah.
the lymphatics and working uh, rather than just stimulate. See, standard lymphatics is a lot of the techniques that we were taught in standard lymphatics are actually wrong because it stimulates the lymph to work more in the right direction.
Mhm.
If it's working the right direction, it's fine. But if it's working the wrong direction, if you do some pumping, there are some techniques called pumping techniques. It actually stimulates the lymph to work more in the wrong direction. And
I could see that.
and a lot of times there's lymph drainage to different lymph nodes. If you do massage towards those lymph nodes, you're just going to get clogged up lymph nodes in neurolymphatic problems.
Mhm.
So we go all the way to the central drainage, down and up. Both we forget that the normal drainage patterns because if we go that way, you just get more and more clogged up lymphatic vessels and more clogged up the lymph nodes, and that's not what we want.
Well,
So,
I'm excited to do some more
yeah.
of this work with you in person, and
Well, it'll be
I'm planning to
great
dig through your book
yeah.
before then. So
Yeah, so you'll be top of the class when I ask the questions, Jeremy. You'll get all the gold stars.
I'll try to keep my mouth shut then. All right, Raymond. I
Yeah,
appreciate
it's
you
been
taking the
great
time.
talking to you. Yeah, no, it's a pleasure. I always enjoy these sessions. So hopefully your members will enjoy what they've heard and understand it a bit more.
Yeah,
Yeah,
it may take a little bit for some people who are new to this, but for people, I have a lot of people in medical professions listening, and this is just a topic I find doesn't get covered enough, and it relates to so many different systems,
yeah.
from
Well,
your
yeah. I mean,
endocrine
a
systems
lot
to
of
your
people. Yeah,
emotions, everything.
absolutely. And a lot of people I meet say you're selling yourself too short by just focusing on ME, CFS, and the long COVID. This system is important for every part of health, and there's so many diseases, not just neurological
Yeah,
diseases. There's
absolutely.
that could be helped with this, but we need to show this and demonstrate this, and that's I'm meeting up with scientists and people like-minded people who want to do this. So
Yeah,
I'm not stopping yet. We're still carrying on researching and trying to give more and more evidence to support what we're doing.
yeah. Well, we appreciate
So
your effort.
thank you very much, and good
All
luck
right,
with your work as
been a
well.
pleasure to
Okay,
talk to
and
you.
I'll see you. Looking forward to seeing you next year.
Next year. All right, sounds good.